Hi everyone, my name is Brett Ramp and I am the EMS Academy Director at Advanced Medical Transport. I really appreciate the opportunity to present today or tonight whenever you're watching this. So, we're going to talk about the art of processing and obtaining the patient refusal. I know it's not the most exciting topic, but nonetheless it's a very important topic. I like to tell employees, students, in primary EMS education, we really fly through the preparatory content such as medical, legal, ethical, lifting, moving, etc. But these topics are the ones that get EMS providers in trouble. These are the topics, these are the situations that end EMS providers' careers. So we really need to emphasize the importance. And hopefully I'm going to do that today as we talk about processing and obtaining the patient refusal to prevent litigation. So the first thing I want to do is show a video, and this video has been circulated quite a bit, but I want you to reference this as I go through the presentation. Did these EMS providers process and obtain a patient refusal like they should have? Or are they responsible for what happened to this patient? And then when we get towards the end, I'll show you a follow-up video of the outcome of the patient. And then we'll run through some case studies.
Hey, come over here. Hey, the ambulance is over here. Come on. We're trying to get you help, bud. Go over and see the girls in the ambulance. Come on. Come on. Go over see the girls in the ambulance. They're going to get you the help. They just want to check your vitals. That's all they're going to do. Come on. That's all they're going to check your vitals. Make sure everything's okay. Have a seat.
Come on in there so I can get up in here.
Have a seat.
Sit down. Just sit down.
So you have to talk to us. Alright? What's your name?
I never heard it.
Yeah, the little kid. Give me the little kid. You speak English? Hey. Hey.
That's all of it again. 1 minute he's head up, eyes up, looking around. Next minute head down.
Give me some out of me.
Yes, ma'am.
Yeah. Get ready to wake up. Pleasure. Or you want me to have pleasure? Pop it. Right. Breathe that in.
Here. Talk to me. Talk to me. If you don't want it up your nose, then talk to me. Stop acting stupid. You're a grown man. And what's going on? Don't shrug your shoulders and do your hands. Tell me. Open your mouth and talk to me. What's going on? Why are they out here on the interstate with you? Say. Hello? Hello? I'm not playing. What's your name?
Give me a hand. Hand.
What's your name? What's your name? Hello? What's your name?
He's breathing right in. Oh, yeah, he is. 124.99.
What's your name? Huh? You can talk.
Hey, you speak English?
Yes.
Yes.
I think they're transferring before. What's your name?
I'm gonna give that a minute. All right. We gotta get your name. Hit me up.
What's your name?
What's your name? It's funny.
You don't have to be reluctant. We all just trying to help you out, bud.
All right, so check this out. Can you please tell us your name so you can take this out your nose? I know it stinks. We know it stinks. Come on, partner. It's just your name.
Everybody here's just trying to help you out, bud.
I'm transporting before. I can't remember where I'm transporting from.
You want to try it again?
Yeah. What's your name?
I was going to hold on. Let me adjust it. Relax as normal, okay? Thank you.
118. I wish mine was 118.
What's your name? Hello? What's your name? Everybody's got a name? Yeah?
What's
your
yours? What's your name? It's okay.
You don't want to say it in front of the police officer? Is that
I
what
told
it
him my name was Cliff. I tried to talk to him a few times. He didn't want to talk.
is? You still
You want to write your name down? Can you write your name?
Maybe a white or something. I ain't white.
If it's an act, it's a pretty good act.
Yeah.
Because I see the same thing when I see a variety of drugs being used.
Yeah.
Now, if you're taking something, we're not here to judge you.
What you been
You want to
taking?
get treatment. If you're taking anything, we're going to get treatment for it.
What you been taking?
We all just want to make sure you're okay. That's all we want.
So exactly what they
Alright,
find
give me a
him running down the highway or something?
Supposedly he was naked on top of the cab of a tractor. The driver said he picked him up. He doesn't know a whole lot. He can't tell us anything.
Where are you from?
This young man's not saying anything.
You ain't got no ID?
Hey, where are you from? Seriously, talk to us. We want to get you some help.
I just want to go to the substation and go to sleep. So if you tell me your name, we'll let you go so I can go back to bed.
She's being serious.
I'm being fucking serious. I'm sleepy. Give me a damn name so I can go home, for real. I'm tired.
What happened to your arm? You been walking? How long you been walking?
That's from that damn blood pressure cuff that
Oh.
she just took off.
Leave me alone. I'm sleepy
Come
too.
on.
We're all sick here, okay?
Please give me your name so I can go home. I know you know what the hell we're talking about because you're sitting there laughing and
What's your
bullshitting. So tell us your damn name, please. Rodrigo? There you go.
How about David? How about Kevin? How about Charles?
Can you please tell us your name? I really like going home. For real. I'm sick. I don't feel good. Do you want to go home? Or do you want to go to the hospital? Or do you want to go to jail? The choice is yours. I can provide any of the three. So where you want to go? So where you want to go?
Like Sean.
Hello? Where you want to go?
These ladies can't be out here all night like this. None of us can.
As long as you don't talk,
You're tying up a lot of resources. We're trying to help you. Okay? If you don't want to go to the hospital, you can go with me. Those are your choices.
Talking in about the next 5 minutes.
You're going to be less than that. Because I've been playing this game for far too long. I've been very patient with you. We want to get you some help. That's all we want. Okay? Do you want to go to the hospital? Because if not, you're going with me. That's how I'm going to solve this problem. I'm a patient man, but I've been out here for a long time.
160 over 78.
What's your name?
All right, hold on. Let's try something a little different. Hand me a piece of paper.
What's your name? It doesn't matter what language he speaks. He can speak his name.
Right. What is...
He's not a retard.
No. But if you don't want to talk, he can read.
He understood what I said. He read my lips.
He's laughing with us. He knows what we talking about. Yeah, see?
What's your name?
Pudding, ask me again, I'll tell you the same.
What's your name?
We're not going to sit on the side of the road all night with you. So what's your name?
What are you looking at me for? You full of shit, bro.
Yeah, he is. Yeah, he is. What's your
All right.
name?
You don't want to talk to us? Yes or no? We know you can talk. We know you can understand us. You know, you got to be real with us. What is your name?
Shake your head, or if you do,
Okay.
you don't.
Do you want to go to the hospital? Yes or no? Do you want to go to jail?
Well, those are your two
Then
choices.
come on, I'm going to give you a ride. You don't want to go to the hospital, Leo? So let's go. His vitals are good, ladies?
Yes.
All right. Come on. I'm going to give you a ride. Do not walk on the interstate. Walk right on the shoulder road. You're not going to jail. You're not under arrest. I'm going to give you a ride. I ain't giving you a ride to jail because if I was going to give you a ride to jail, you'd be in handcuffs. You're not in handcuffs. You're not under arrest. I'll figure out where you live. Give you a ride to a safe environment. That's all I want. I want to make sure you're all right. That's why I get EMS down here. Check your vitals, make sure you're okay. Hop on in, we'll get you a ride. You put your seatbelt on for me? You taking him CNT?
So looking at that video, did those EMS providers do this patient any justice? Did they properly process and obtain a refusal? In my opinion, no. And when I show you the follow-up video, that evidence will support my reasoning for that. And other things that they did to this patient was outrageous. So why are refusals so serious? Yeah, they only account for 15% of the calls we respond to, but they are one of the most commonly litigated calls in EMS. If you are going to get litigated against, it's probably going to be a refusal. These are the calls that kept me up at night or kept me up during the day when I worked third shift. When I left that patient's residence or wherever the patient was at, what happened to them? Did their illness, injury get worse? Did they die? Did I do everything in my power to educate them, to allow them to make an informed decision to stay home? And these calls are the most dangerous for us, and not because of the situations that we're presented with, it's because of the liability of not taking the patient to the hospital. So we need to make sure we're taking the time on these type of calls and doing our patient justice, making sure we're following the policies and procedures to prevent against litigation. This stat at the bottom scares me a little bit. 70% of patients 65 years and older require follow-up care So if you go on a patient that is in that age range, most likely they're going to require follow-up care. And they are more likely to die within 1 week of initially seeking treatment. That's even scarier. So how do we process and obtain the patient refusal? Lots and lots to remember. However, a couple years ago I found this acronym called Case Closed, and it's going to help us do that. So this was originally written to help or aid in writing a well-written PCR, but it does a wonderful job helping the EMS provider process and obtain that patient refusal. So you can see all the different categories, and we're going to talk through those as we progress through this presentation. And I can share this presentation with you guys if you want at the end, so you can have this to reference. So starting with condition, capacity, and competency. So the first thing is condition. What was the patient's chief complaint or complaints? What is their HPI? Next is who called and why did they call? Understand, if right now I suffer a medical emergency and I pick up the phone and I call 911, that was purposeful, intentional. I was scared, I was concerned enough, something was going on, I picked up the phone and I called for help. There is a stark difference between a passerby, for example, calling 911 because they thought someone or something may have happened, versus the patient or maybe a family member or a loved one telling you that the patient is not their self or there's something wrong with them. So it's really our job to identify the concern someone has, which led to 911 being called, and then we need to address or validate those concerns through an appropriate assessment and history. Is there validity in why 911 was called? Is there a legitimate illness or injury occurring in this patient? Do they need definitive care? The next thing that we need to look at, and I think is the most important, is we need to determine decision-making capacity. And in order to determine decision-making capacity, we have to look at capacity and competency. You often hear capacity and competency used interchangeably, but they're really two separate things. So capacity is a functional assessment and clinical determination made by the EMS professional. You go out and you start assessing your patient, you start getting a history, putting all the pieces together from the HPI, the chief complaint, and you are going to determine the capacity. Competency, on the other hand, is a legal determination made by a judge. So a judge could determine someone incompetent due to a health issue such as dementia or a psychiatric disorder. Another big one is emancipation. Obviously, if a patient is under the age of 18 and they're not emancipated, they have to have a legal guardian make decisions for them. But if they're emancipated, they can make their own decisions. Other reasons that are will consider a patient to be emancipated: pregnancy. Also in the state of Illinois, once the mother gives birth to the child, they're still emancipated per Illinois state law. Active military status, an emancipation order. So I've ran across a couple people that were under the age of 18 and were emancipated, or I've heard of individuals who have been emancipated. And then marriage. Those are all the reasons someone could be emancipated. So when we look back at decision-making capacity, two categories: capacity, which you are going to determine as the EMS professional, and then competency, which is a legal determination made by a judge. A patient has to have decision-making capacity in order to refuse transport to the hospital. In the video I showed you and some of the case studies that we're going to discuss, it all goes back to decision-making capacity. Did the EMS professionals, did the EMS providers do a good job in determining if the patient had decision-making capacity to refuse? And a lot of times they did not. Understand that simply documenting that the patient was alert and oriented is not sufficient. You need to do a thorough assessment, get a thorough history in order to really determine if a patient has decision-making capacity. Other things you need to look at: are they under the influence of drugs or alcohol? What's their behavior? What's their speech pattern, etc.? That all goes into, does my patient have decision-making capacity? So I'm using this as an example. Depending on what system you're in, this might be different, but if the system you're working in has a refusal form that has tools on it, it is best practice to use them. So in the system I am in, on our refusal form, we actually have 10 questions. It's the very first section of the refusal form, and it's going to aid us in determining if a patient has decision-making capacity. So you see the 10 questions here. If you answer yes to any of those, it's like a stopgap. It's a, hey, you know what? This patient might not have decision-making capacity, so you need to consult with medical direction. And a lot of these are self-explanatory, but some of them that we forget about: language barrier, right? That's a huge issue. If you cannot communicate with the patient, if the patient does not understand the risk, can they make a decision to refuse transport? No, they can't. And then the last one: is the patient under the influence of alcohol or medication to the point of altering judgment and or decision-making capacity? This is big. If I have 1 or 2 beers, yeah, probably not to the point of altering my judgment and decision-making capacity. However, if I have 6 beers, I'm slurring my speech, I have an unsteady gait, I can't sit upright in the chair, I have a strong odor of alcohol in my breath, yeah, that's a little more concerning that I don't have decision-making capacity. So, takeaway point here is, if your refusal form has a tool to help you determine decision-making capacity, use it, because it's going to protect you if you would be litigated against. And at the end of the day, the patient has to be able to communicate. They have to be able to communicate their choices without extreme indecision. They have to understand the risk, the benefits. They have to appreciate the illness or injury and the outcomes. And then they have to be able to reason. And all those go into decision-making capacity or decision-making ability. The other thing, which is pretty neat, that our refusal form has on it, it has a brief mental capacity evaluation. Again, this is a tool. If you have it, you should be using it. It's going to help support your decision to say, yes, this patient needs to be transported to the hospital, or, you know what, this patient does not need to be transported to the hospital, or, you know, they don't want to go. I think they need to go, but they don't want to. They have decision-making capacity. If you have it, use it. And this is just an example. So if they score so high, it indicates that they are impaired in regards to decision-making ability. So take-home point here is, if you have decision-making tools on your refusal form, use them, because it's going to help support your reasoning for not transporting the patient to the hospital. The next thing we have to do is we have to do a thorough assessment. I feel like on patients that refuse, I do a much more thorough and comprehensive assessment than I do on any other patient, because at the end of the day, I know if something happens, they are going to thoroughly look through my documentation and make sure I process and obtain this refusal appropriately. So, what's involved in our assessment? We have to get a thorough and clear history of present illness. Why did or who called 911, and why did they call? A past medical history. Some might say, yeah, it's not important, but it is. Is there a current chief complaint? Is their HPI related to their past medical history? Is this an exacerbation? Does this make sense why they are presenting the way they're presenting? The next thing is do a comprehensive or thorough assessment. We want to make sure we're not missing anything. And then obtain vital signs. And I say best practice, get 2 sets of vital signs. This allows us to trend. It also shows that we spent an adequate amount of time with that patient to do a good history, to obtain a good history, to do a good assessment, to allow them to voice their concerns, to allow them to make an educated decision. And last, we need to make sure we're explaining our findings to our patient. Why is that important? One, it allows the patient to make an educated decision about their options and their treatments. If you don't explain it, they're not going to be able to do that. And the other thing it does, it makes it a lot easier for us to reason with the patient on why they should be transported. It gives us that evidence. It gives us that support saying, you know what, you really need to be transported to the hospital and this is why. If you don't do that, if you don't explain the findings to your patient, it might be a lot more difficult to convince them to be transported when necessary. And then at the end of the day, if you don't explain your findings, you're not allowing them to make an educated decision about their options and treatments. And make sure these get in your documentation. Make sure these get in your patient care report. Remember, if it's not in your patient care report, it didn't happen. And I guarantee if you're being litigated against, they're not going to care if you say, yeah, I did that, but I just forgot to document it. It's going to be as if you never did it. So make sure you get it in your patient care report. The next thing we want to do, we want to make sure we're using statements, and this is really for your patient care report in regards to the patient's chief complaint or the HPI. So in this example, I slipped and fell in the bathroom due to a wet floor. My wife just mopped all the floors in the house. So this is really telling you that, there wasn't another illness or injury that precipitated the fall. It was due to a wet floor. The next thing you need to do is make sure you get the understanding of their condition in their own words, an understanding of the risk involved. I know I could die if I don't go to the hospital and something is wrong inside my body. By putting this in your PCR, putting this in your final document, it's going to support that the patient understood. They understood their condition and they understood the risk. You spent the time to inform them of their condition and inform them of the risk. And then at the end of the day, they have to understand that by signing the refusal form, they are taking the responsibility of the consequences involved, so long as you did your job. Another thing we need to do is we need to make sure we are educating our patients. And when we do this, we need to use plain language. So don't say, oh, I think you're having an acute myocardial infarction. Instead, I think you're having a heart attack. So they can understand what you're talking about. We need to educate them on their treatment options, and that goes for the treatment that we're going to provide and the treatment they could receive at the hospital or a prompt care, etc. And then we need to educate them on the risk of refusing. Again, this is going to help them make a better medical decision. It's going to make them make a better decision on if they are going to stay home or if they're going to allow transport. Just think about if you told a patient that you think they're having a heart attack. The heart attack could cause you to go into an arrhythmia, which could cause death. The heart attack could cause your heart muscle to die, and you might have heart failure, which could cause life-altering debilitations. If you tell a patient that, it's probably going to make a difference. It's probably going to be like, you know what, yeah, this is serious. I need to be transported to the hospital, versus you don't tell them any of that. At the end of the day, we have to provide all and enough information that a reasonable person would find necessary and relevant to make a medical decision. Essentially, we have to give them enough information so that they understand what would be in their best interest. If you don't do that, you're not doing your patient any justice. And on our refusal form, we have a tool to help do that. We actually have, in the system I'm in, educational instruction sheets, and this is on the back of the refusal so we can tear it off and we can leave it with the patient. So let's say this patient is complaining of chest pain. So we can see in the upper left-hand corner here, chest pain. Right there, it's going to list things that you can educate your patient about. There are many causes of chest pain. The cause of your chest pain cannot be determined. Avoid activity that increases your pain. If you smoking, quit. So these can get pretty comprehensive. Take deep breaths each hour, even if it hurts. If you take medication for chest pain, take your medication as directed. And then it goes into when you should call your doctor, go to the emergency department, or call 911. Your pain worsens with activity. You develop difficulty breathing. You have blood come up with your cough. You develop black or sticky stools. You faint, etc. It's going to give you something to go off of. So if you're searching for, what risks are involved, you could use this sheet. And again, it's best practice. Put a check mark or circle whatever the complaint is and leave that with the patient. And you need to make sure you're documenting that you did that. We need to explain the consequences to the patient. What are the consequences if you refuse transport and you stay home? Please don't use the blanket term. You could suffer from further illness, injury, or death. You need to be specific. So, chest pain patient, you could be suffering from a heart attack. You could be suffering from a blood clot. You could be suffering from an aneurysm, etc. You need to be specific because it's going to allow the patient to make a better decision. And at the end of the day, the patient should be able to evaluate the consequences. They should be able to weigh the risk and benefits, and then they have to be able to reach a conclusion with keeping their goals and best interest in mind. Okay, so be specific with whatever the complaint is. Don't use the blanket term. And the same thing, follow this up in your patient care report. List out every consequence you told the patient. Again, it's going to support that you really did spend time with the patient and you allowed them to make an informed decision. So the next thing we have to do is we have to let the patient know of our limitations. This is diagnostic and treatment limitations. The example I like to use, patients having chest pain, you do a 12 lead. The 12 lead is unremarkable. So we tell the patient, we took a big picture of your heart to see if you were having a heart attack. It was unremarkable. It didn't show anything. However, this big picture of your heart cannot rule out an MI. It can only rule one in. So at the hospital, they could draw your blood. They could do more EKGs. And that could determine if you are in fact having a heart attack. So that's just one example. The other one, traumatic injuries. We can't do CT scans. We can't take x-rays. You could have internal bleeding that we cannot see. This allows the patient, again, to make an informed decision about being transported to the hospital. And follow this up in your patient care report. Patient was informed of the limitations of EMS. Offer transport and offer it frequently. We should never start our patient assessment or our patient encounter with, do you want to go to the hospital? If you do that and they say no and they really need to go or they don't have decision-making capacity, you're going to have to backpedal and it's going to be a little more challenging for you to get them transported. I always like to tell providers you should start off by introducing yourself and then asking them why they called. If that is your first statement, you may come across the patient as if you don't care, if you're in a hurry, if they're being bothersome. So try to avoid that statement when you first encounter a patient. The other thing that has been found is offering treatment and transport just once is not enough. If you offer it multiple times, it gives the patient enough time for you to address their fears or maybe their concerns, why they don't want to go to the hospital. And then it gives you multiple opportunities to really convince the patient, if necessary, they need to be transported to the hospital because it's what's in the best interest for them. This is us as EMS professionals being patient advocates. It shows that we took the time with our patient and we didn't just rush off the scene. We gave them the opportunity to ask questions. We were given the opportunity to address their concerns. Remember, if a patient picks up the phone and they call 911 because they have an illness or injury, and then you get there and you start assessing them, and all of a sudden they say, no, I don't want to go, that should really stop you and make you inquire to why they don't want to go now. They were scared, they were concerned enough to pick up the phone and call 911, but now they don't want to go. What's the reasoning? Is it a financial concern? Do they have family members at home that need cared for? Do they have pets at home, etc.? We should be taking that time to figure that out, and if necessary, making arrangements if they truly need to go to the hospital. And then again, follow up in your documentation how many times you offered transport. Next, we got to make sure we get that signature on our refusal form. So remember, the refusal form is a legal document and it must be signed by either the patient legal guardian. Remember, a legal guardian could be, for example, a parent. Maybe it could be a healthcare power of attorney. It should include a witness. And in most EMS systems, the preferred person is a police officer. Remember, this is a respected individual, someone not on the primary healthcare team. And this witness really serves as the person saying that, yes, EMS was here. Yes, EMS did an assessment. They obtained a history. They explained the risk and consequences to the patient. The third signature is the EMS provider. Again, if your refusal form has 3 spots or there's 3 signatures required, make sure you're getting those. It's best practice. If litigation would be brought against you and those signatures are missing, you're going to be scrutinized. So try to get all 3 signatures if that's how many spots you have on your refusal form. So here's another example of our refusal form. So the last couple things we talked about. So section 1 and 2 here. Number 1, EMS explain the potential known and unknown problems, including but not limited to. So this is your opportunity to document on the refusal form known and unknown problems that you verbally discussed with your patient. And then check the box. Patient is able to verbalize understanding of their clinical situation. Remember, they have to understand their clinical situation in order to be able to make an informed decision or to have decision-making capabilities. And then section 2, EMS explain potential for fatal or permanently disabling consequences, including but not limited to. Again, that verbal discussion you had with your patient, list those right there. And again, patient is able to verbalize understanding of risk. Yes. If not, our system says you have to consult medical control. But again, that should be a red flag to you. You know, if they can't verbalize the understanding, do they really have decision-making capacity? You could check, advise patient to seek care within the emergency department or physician as soon as possible. We should be telling our patients that. And then advise the patient to call 911 or their local EMS if their condition changes or they change their mind regarding care and transport. And I'll talk about follow-up care and calling 911 in a couple of slides here. Same thing with what's the patient's plan. And then you can see section D is patient signature. So check the box that we recommend treatment and or ambulance transportation on behalf of who. So myself, minor, or other. So healthcare power of attorney. And then the statement right here, we have been so advised by pre-hospital medical personnel that treatment and or transportation is recommended. Hereby accept all responsibility connected with our refusal and release the EMS provider, agency, their employees, medical personnel, administrative, and executive officers from any and all liability or claims resulting from any such refusal of treatment and or transportation. That right there, that's really important that you're explaining that to the patient. However, you have to make sure you did a good job of educating the patient, making sure they have decision-making capacity, and allowing them to make that educated decision. But you should be taking the time and saying, this is what you're signing. We've informed you of the risk. You've been able to make that decision. You still don't want to go with us. That's what that signature is for. And then you can see the 3 signature sections at the bottom. Educational material, we talked about this. We should be educating our patient. Leave this, if able, with your patient. So in my system, we can tear it off the refusal, check it, circle it, whatever, highlight it, and we can leave it with the patient. Okay, and you have to document that in your PCR that you left that with the patient. Again, this is just supporting that you really did do a good job. You took the time, you educated the patient, and they were able to make an informed decision. This is just like getting discharged from the hospital. So if you've been discharged from the hospital, the nurse comes in, sits down, and goes through a whole packet of discharge instructions. This is really what we are doing for the patient. Last thing you need to do is you need to make sure to tell the patient that they can call 911 back if necessary. There's actually a case where a husband and wife, the husband had a medical emergency, the wife called 911, EMS get there, and the patient, the husband, doesn't want to go. They get a refusal on him. What they did not do is tell the wife that she could call 911 back if needed. They leave, the patient goes into cardiac arrest. The wife does not call 911 back because she did not think she could. She sued and she was successful. So I know it sounds ridiculous, but make sure you tell the patient they can call 911 back if necessary, and make sure you document that in your PCR. Okay, so next thing I'm going to do, I'm going to show you the follow-up video of the case I showed you at the beginning to reveal the outcome of this patient.
2018 began under the most unusual of circumstances, with police coaxing a naked Tarashuk down from the top of a tractor trailer on the side of I-95 in Santee, Orangeburg County, South Carolina.
No, I'm fixing my truck. You're fixing your truck? Yeah. Naked?
If you ask Cindy and Paul Tarashuk Sr., they will tell you they believe the initial police interaction with Paul should have ended with him safe, alive, and home with them. Instead, an Orangeburg County Sheriff's deputy decided to drop off Tarashuk, half-dressed, with no shoes and no ID, at a random gas station in the middle of the night. A few hours later,
I think I just hit a person.
the 26-year-old New Jersey native was struck and killed on I-95 after he wandered into traffic.
It's terrible what they did to him. They didn't follow any of the training that I know they had.
Paul suffered from schizoaffective disorder, a mental illness that led to delusional behavior. Members of 4 different South Carolina agencies came into contact with a delusional and unresponsive Paul Tarashuk that night before his untimely death.
The police officers in EMS, they take an oath to serve and protect. So they should have brought him to the hospital or brought him to jail.
Russell Burke is the Tarashuk family attorney in South Carolina.
I think what we have, frankly, is somewhere between gross neglect and intentional harm.
Tarashuk shut down and stopped talking by the time he was inside the ambulance, and EMTs seemed to have already mentally clocked out.
Breathe that in.
Their message was clear. Their patience had worn out.
You don't want it up your nose, then talk to me. Stop acting stupid.
As they shoved potent ammonia capsules up his nose in an unsuccessful effort to get a response out of Paul.
I was being serious. I'm sleepy. Give me a damn name so I can go home.
They could see his brain wasn't registering the pain that his body was in from that ammonia inhalant.
Do you want to go home? Or do you want to go to the hospital? Or do you want to go to jail?
In the end, it was none of the above. A few hours later, Paul Tarashuk was struck and killed by a driver on I-95.
Yes, I busted out my windshields and I know I've totaled my car.
For Cindy and Paul Tarashuk, in those quiet moments in a home filled with Paul's photos and the plants he loved and cared for, there are still painful reminders of a parent's loss.
How do you live without your kid? I don't know. I haven't figured that part out yet.
Jay Dow, Pix 11 News.
All right, here's what we know. South Carolina suspended 2 EMTs for 6 months, but deferred those punishment if the EMTs stay out of trouble. Whether or not any of them violated policy is still under investigation.
Okay, so before we get into a refusal example, ultimately a patient died, and in my opinion, and I think the opinion of most, is that the 3 EMS providers did not do the patient justice. The patient died because of their lack or their negligent care. Did the patient ever verbally respond? No. I can count one time where he nodded his head, and I think it was in reference to his name. Okay? So how in the heck can you determine decision-making capacity? You can't. The other thing that just appalls me is they stuck an ammonia inhalant in this patient's nose. We've all smelled ammonia inhalants. We've all probably used them on patients appropriately, I hope. And that smell is just, it immediately gets a response from you. So could you imagine shoving that in someone's nose and it didn't even faze him? That should have been a red flag right there. They did get a blood glucose, they did get a blood pressure, but their assessment was limited to that. Did they do a neurological assessment? Did they really take into consideration that he was naked and he was on top of a semi on the interstate? That's a huge red flag right there. If a person is doing that, they are not in the right state of mind. They are not able to make decisions on their behalf. They did not complete any refusal paperwork. He was turned over to the police department. They took him to a gas station. He went right back out to the interstate, and he got struck by a vehicle and killed. If they would have followed the case closed acronym, if they would have done the stuff we just talked about, this patient would have been transported, or should have been transported to the hospital, and probably would still be alive. So please take the time. Make sure your patient has decision-making capacity. Make sure they can make that informed decision before you obtain that refusal. Again, if someone asked me what call I would rather have at the end of my shift, and one of the options was a refusal, and the other option was a transport, I would not choose a refusal. These calls generally take longer because you have to do a very comprehensive, thorough assessment. You have to spend time with the patient to make sure they understand the risk and they're informed, they're educated. And then the longest part is your documentation. And so here is a generic, this is an example, this is not a real call, but if you read this, this has all the components that we just talked about, and this is going to protect you from litigation. Your refusal documentation should be the longest documentation, the longest narrative that you write, making sure you are covering your bases, making sure you're protecting yourself from litigation. So I'll give you guys a couple minutes to read this, and then we will talk about it. Okay, so if we look at this PCR, this narrative example in the subjective section. And I don't care what format you use as long as the information is there. I like to use the SOAP format, but a lot of people like to use the chronological format, and that's fine. Just make sure the information is there. So in the subjective section, we have a clear history of present illness, we have a clear chief complaint, and we have clear pertinent negatives. Also, patient denies any recent drug or alcohol use. I would say on a majority of my refusals, I'm asking this question because it just supports the fact that they are not under mind-altering substances. So it goes back to they did have decision-making capacity. And in one of the case studies I'm going to show you, family denies that the patient was consuming any drugs or alcohol, but the fire lieutenant said, "Oh, it appears they're just intoxicated," and that was not the case. So again, this is just going to support your assessment, your history, and shows the patient did have decision-making capacity. Next thing, in the objective section, we have a clear, comprehensive, thorough assessment. It's documented the patient is conscious, alert, and oriented ×4 and able to answer all questions appropriately. Again, alert and oriented ×4, probably not enough in itself. Follow that up with patients able to answer all questions appropriately. Speech is clear, no odor of alcohol on the breath. Let's see. Then my assessment was refusal, post-ground level fall, no complaints. And then your planned treatment. This is probably the largest section. So patient didn't want to be transported to the hospital despite being explained the risk, and the risks are actually listed. Internal bleeding, fractures, other injuries not known to EMS. That's important because we really don't know all the injuries that they could possibly suffering from. And these could lead to further illness, injury, disability, and or death. So that's fine. Use that blanket kind of generic statement at the end, but you need to be specific on what type of injuries or illnesses they could be suffering from. Limitations of EMS is listed, so no diagnostic equipment available such as CT scanners or x-rays. Again, this allows the patient to make an informed decision. Patient still wish to refuse, so twice I have documented patient wishing to refuse. Vitals taken, and then I add in there that the pure ARMS refusal mental capacity exam was performed. This supports that I truly did determine patient had decision-making capacity. And I tell you, patient scored a 0, which indicates normal mental capacity. Patient once again offered to be transported to the hospital, still wished to refuse. So that's 3 times they were offered. Patient signed refusal form and acknowledged that he understood the risk of refusing transport to the hospital. That's important. And then I put a statement in there in quotes. "I know I could die if I don't go to the hospital and something is wrong inside my body." Patient left with a copy of the refusal form, so if you have the ability, leave a copy with them along with the instruction sheet so they can reference that if something changes. And then patient told to call 911 back immediately if needed. What's his follow-up plan? What's he going to be doing? So patient would be staying home with his wife. She was also told to call 911 back if needed. So if something happens to the patient, he's going to be home with his wife, and she knows to call 911 back if needed. So that's reassuring. Like, what is his plan? If something would happen, he's with someone that could call 911 for help. So this is just an example, but at the end of the day, remember your refusal documentation should be the longest in most situations, PCRs that you write. It should paint the picture that the patient had decision-making capacity, they were informed of the risk, they were educated. Again, this is going to help protect you from litigation. If it's not in the document, you didn't do it, no matter what you say, no matter how much you try to argue. Okay, next thing we're going to do, I'm going to go through 3 different case studies. Okay, case study number 1. So at 0300, a mother of a 30-year-old patient called 911 because her daughter was passed out in the bathroom, was drooling, and had a swollen lip. When EMS arrived, patient was crying hysterically, complained of having a headache and sensitivity to light and sound, and having vomited. No drugs or alcohol were reported, and patient had given birth via C-section 2 weeks prior. So with this information alone, I'm a little bit concerned that she has a headache and sensitivity, especially to light, and has vomited. So what does that scream to you? some type of head injury, maybe meningitis, maybe a CVA. So some concerning things with just those complaints alone, especially with no drug or alcohol consumption. The next thing is the fact that she gave birth 2 weeks ago via C-section. We know that there are risks, there are complications postpartum. Infection, postpartum depression, blood clots. And I'm not saying all those are related to her presenting complaints, but in itself, postpartum period is a little bit risky. So just based off this information, I myself am a little bit concerned that something possibly could be going on with this patient. So the patient's mother asked EMS multiple times that they were taking her daughter to the hospital, in which the fire department lieutenant stated that the patient looked like she had too much to drink and there was no reason for them to take her to the hospital. Patient's mother then asked EMS if they could help her daughter down the stairs to her car so she could take her to the hospital, and they did that. En route to the hospital, the patient started having seizures, and this is with her mother in the car. They get to the hospital, a CT scan is performed. It revealed bleeding on the brain due to an aneurysm. The patient remained comatose and died 5 days later. So if we go back to the start of this case study, that all makes sense. She had a headache, she vomited, she had sensitivity to light and sound, and she was found passed out in the bathroom. So did she have a syncopal episode? Did she have a seizure? All those presenting signs and symptoms really make sense for her diagnosis. EMS did not take vitals. They did not perform a comprehensive, thorough physical assessment. It was merely a visual assessment, and they documented the call as canceled, and there was no patient found. What was the result of this? Almost a $3 million settlement. If we look back at everything that I discussed, they didn't do anything in the best interest of this patient. They did not determine decision-making capacity. They didn't do a thorough comprehensive assessment. They didn't do vitals. Okay. They did not educate the patient. They did not inform her of the risk. If we think back, an entry-level EMS provider knows what the signs and symptoms of a stroke are, and she really screamed stroke based off her presenting signs and symptoms. And then what's even more concerning is they documented the calls canceled, no patient found. So, we're in a totally different ballgame now. That's falsifying documentation, because they did have patient contact. There was a patient there. It wasn't just a canceled call. Next case. Parents of a 16-year-old called 911 after he was found unconscious. However, patient was conscious upon EMS arrival, but he was altered. Patient's father informed EMS that they did not want or need their medical assistance, so EMS left. Again, a 16-year-old that's unconscious, that's concerning. Most 16-year-olds don't have comorbidities, medical problems that are going to result in unconsciousness. So I would definitely be concerned what's going on with this patient. And the fact that the father says we don't want or need medical assistance, I would be investigating that a little bit further. Several hours later, the patient's condition further deteriorated and another 911 call was made. When EMS arrived, the patient was in cardiac arrest. So the patient died due to a drug overdose, and the autopsy or toxicology report revealed that he died of anoxic encephalopathy caused by cocaine and opiate intoxication. No full assessment was completed during the initial call. No refusal documentation was completed for the initial call. And no run sheet was completed for the initial call. I know and I understand that every agency, every system has slightly different SOPs. But if you make patient contact, if the person who 911 was called for is there. You should be doing an assessment. You should be getting vitals because it's going to protect you in the end. It's going to be a he said, she said situation if something happens and none of this was done. And you're not doing your patient any justice. The other thing is if you have a refusal document, it has to be completed. Especially the system I come from, it has a lot of great tools on there that support the reason, or it supports that the fact the patient had decision-making capacity or they didn't. So it's going to support, yeah, you know what, I'm comfortable with you staying home, or you know what, you don't have decision-making capacity and you need to come to the hospital. And there was no run sheet. So you know, some agencies might not use run sheets, but this agency, they did use them. So when you don't complete a run sheet, that's kind of shady. Like, why did you not complete that? So the previous 2 case studies, there was documents that normally are completed that were omitted. That screams, yeah, we knew we did something that we shouldn't have. The verdict of this, a $5.1 million verdict. And the last case study, a patient took a handful of pills, chased them down with some alcohol. The husband called 911. When EMS arrived, they found the patient semi-conscious. They found an empty pill bottle, and then they found 2 small empty liquor bottles nearby. The empty pill bottle was for an old prescription. Her current medication did not have many pills missing. So right away I'm concerned, semi-conscious, okay, we could receive further clarification on this, but semi-conscious to me means that, she's not conscious, alert, and oriented times 4, so right away she doesn't have decision-making capacity. She's under the influence, per husband, of alcohol and or drugs. So, is there an assessment to disprove that? And then a whole prescription bottle's empty. Yeah, it's an old prescription. How many of us have old prescriptions in our medicine cabinet? We all do. Probably have tons of them. So there's really no merit to that. There was a cryptic note left by the patient stating she was sorry, but it really didn't specify suicide. Per the husband, the patient had been placed in protective custody before for suicidal ideations. EMS assumed the patient was simply under the influence of alcohol and should just sleep it off. EMS did not transport the patient. The patient died 7 hours later, and the toxicology report found the patient had more than 30 times the normal dose of nortriptyline. So this is a tricyclic antidepressant. It was the same medication listed on the empty pill bottle found on the scene. So the verdict, $190,000, which in my opinion is not enough at all. If we look at the previous 2 case studies, were in the millions, and this one, $190,000. So I'm not really sure how they came to that amount. But looking back, the husband, most likely a reliable source, is telling you the patient's been drinking, took a whole bottle of pills. That should be enough right there to say, you know what, this is a suicide attempt, or you have suicidal ideations, we have to transport you to the hospital, we have to put you in protective custody, or a consult with medical direction. And the fact that one of the pill bottles was empty, was there any inquiry with the husband? Does she still take these, etc.? And it resulted in a patient's death. So that is all I have for you guys. At the end of the day, remember, refusals are one of the most litigated cases in EMS. So please take your time, do your patient, their family, their loved ones justice. Make sure they have decision-making capacity. Make sure they're informed, educated of the risk. Make sure they know their treatment options. Do comprehensive, thorough assessments. Make sure you get vital signs on these patients, because at the end of the day, it's going to protect you. You don't want to end up in any of the 3 situations I talked about at the end. And the sad thing is, in a lot of these cases, these EMS providers still have their job. And in my opinion, the cases I talked about is just gross negligence. We know better. We learn from day one in our primary education that you have to determine if a patient has decision-making capacity to refuse. You have to do a good assessment. You have to get vitals. So if anyone wants this presentation, I can share it with you. There's my email and there's my office phone number. I'm welcome to any questions you may have. Again, I appreciate the opportunity to present, and I hope it was beneficial and you guys enjoyed it. Enjoy the rest of your day or your evening. Thank you.